and welcome to another installment of ISTH Congress Daily News. My name is Cy Wilkins, and I am a clinical member on the hematology service at Memorial Sloan Kettering Cancer Center and Weill Cornell Medical College in New York. Today, it is a pleasure to be joined by Dr. Nina Buchtele.
All right. Thank you so much for the invitation to this beautiful interview, and also thank you very much for giving me credits to the presentation. And hi to everyone from the ISTH community. So. Um, my research focus has actually focused around different areas of coagulopathy in patients receiving extracorporeal membrane oxygenation, so ECMO in short. And the PROTECMO study was one project we have contributed as one of 41 participating centers from 19 countries across the world. So it was a multinational project that was actually led by Gennaro Martucci from Palermo, Italy. And the actual idea of the PROTECMO study was to collect very granular linear longitudinal data on patients receiving VV ECMO and actually address different topics in a primarily descriptive way at first. And some of these topics have already been published. So the first publication was about using different transfusion thresholds across these VV ECMO patients and what their impact actually on clinical relevant outcome would be. The second study that has already been published from this group was about anticoagulation strategies and the impact on especially bleeding complications. And what we have seen in these analyses is that from the second paper, from the anticoagulation paper, that probably not that surprising, thrombocytopenia was an important risk factor in a multivariate model on bleeding risk. So we thought about using the data we've already collected and then take another look at different platelet thresholds and what the actual impact of thrombocytopenia on bleeding complications in ECMO patient is.
So it came from red cell transfusions to anticoagulation. Now looking at my favorite subjects, platelets. Okay. The aim of the study. So what were the specific aims of your project?
Yes. So the aims of the project were actually to, first of all, describe the incidence of thrombocytopenia and describe the incidence of different severities of thrombocytopenia across a very large data set of ECMO patients. The second objective was to assess the clinical relevance, especially regarding bleeding complications of thrombocytopenia in ECMO patients. And our third major aim of the study was to assess risk factors for the development of thrombocytopenia during ECMO and also to assess risk factors for baseline thrombocytopenia in VV ECMO patients.
Okay. And how did you go about, how did you go about this project? Just the
Yes.
highlights.
Overall, we included 652 patients into our analysis with a total of more than 8,000 time points. Apparently, missing data was very, very, very limited. So we had a very good set of complete data.
Okay,
Um,
excellent.
and so, as a first step, going to the main results is that we've seen that about 80% of patients do experience any level of thrombocytopenia during ECMO, which is, of course, a very, very high number. And about 50% of patients do experience thrombocytopenia below 100 gigers per liter. The major risk factors for developing thrombocytopenia before ECMO is if patients are at an immunosuppressed stage, which was present in about 25% of patients, and if patients had bacterial pneumonia as their underlying disease, why they developed ARDS and why they subsequently required ECMO treatment. As a side note, what I have to mention is that our study population also included lots of COVID-19 patients because COVID was booming during our recruitment phase. So 1/3 of patients were actually suffering from COVID-19 related ARDS. So these were the risk factors for baseline thrombocytopenia, but interestingly, baseline thrombocytopenia had no impact on follow-up bleeding events. However, risk factors for thrombocytopenia throughout the ECMO involvement were, again, immunosuppression at admission. It was the age of the patients, and it was a post-operative admission of patients. So these were the baseline characteristics that influenced the risk of developing thrombocytopenia. And from follow-up variables we have assessed, we could identify especially three clinically very meaningful parameters that influence the risk to develop thrombocytopenia, which were septic shock, which was renal replacement therapy, and which was membrane exchange. And overall, we were specifically interested in different platelet indices, whether four different platelets indices could help us in predicting bleeding events. So, first of all, we assessed what is the meaning of the absolute platelet count. Then we assessed what is the meaning of the absolute platelet drop if we compared baseline thrombocytes with the respective event. So, if just the absolute difference could have a meaningful impact for predicting bleeding events. Then we assessed the relative change from baseline thrombocytopenia to the index event, and we assessed whether the duration of thrombocytopenia itself had an effect on developing bleeding events. And to put this short, actually, the only relevant variable in this context was absolute thrombocytopenia. And there was a linear increase in the bleeding risk with lower platelet counts, and it was about 4%. It was about of an 4% increase in experiencing bleeding events with every drop of platelets of 10 giga per liter.
Okay, very, very interesting. Very, very interesting. Um, I know as a consultant and seeing patients regularly with thrombocytopenia in the hospital and in the ICU, um, there is a thrombocytopenia of the ICU, correct? Um, what's the big difference between just the thrombocytopenia of ICU, which is a very complex process, and just like this ECMO associated thrombocytopenia. Have you seen any, what's the big difference there, if
Well,
there is?
I think apparently the big difference is that we're supporting the lung with a super huge machine, which of course provides a very large artificial surfaces to the human blood. And of
Mm-hmm.
course, this causes consumptive coagulopathy, it causes contact activation, and it causes just coagulopathy on very, very different levels. So I think that especially platelets are affected by ECMO in many different ways, not only related to the underlying disease, whether it's sepsis or whether it's ARDS, which per se may already cause thrombocytopenia, but it also has got very different mechanisms which are often related to also mechanical complications that may likewise attribute thrombocytopenia during ECMO.
Okay, so this is just thrombocytopenia plus. Okay,
Exactly. Yeah.
yes. Okay, great, great, great. And so for the clinician out there, whether they be a consultant like myself or an ICU and intensivist, what is the clinical kind of takeaway from your project?
Well, so in my view, and also what we as a group interpreted from the data actually was one important thing was we've seen that septic shock was a very important predictor for developing thrombocytopenia. So apparently, control of infectious diseases and maybe also probably antimicrobial prophylaxis need to be revised during ECMO treatment because that would be a modifiable risk factor which we could somehow prevent. So I think we have to provide a maximum caution to working sterile at the circuit and at best preventing any infectious complications. And I think the other very important point we found was that membrane exchanges were significantly associated with the risk of developing thrombocytopenia. And we interpreted this in the way that if you imagine you're having this artificial lung membrane, which per se, of course, may cause consumptive coagulopathy, because with time, the artificial surface will just start to clot. And you will see this as a consumptive coagulopathy in your lab results. And we had the feeling that it's probably justifiable to also exchange these lung membranes at a quite early stage and provide liberal membrane exchanges to prevent actually patients to develop kind of end-stage thrombocytopenia, which may result in also disastrous bleeding complications.
Okay, so take home points there. Surveillance for infection and taking infection very seriously, and then probably exchanging, the membranes more frequently to prevent, less consumption of the platelets. Okay,
Exactly.
excellent, 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 excellent project. Thank you very much for joining us, and thank you all for joining us today. And hope to see you next time.
Thank you.